I'm David, one of the trade fellows, as you all know, and my presentation is on medical aid in dying or voluntary assisted dying, MAID or VAD. I don't have any financial disclosures, but I wanted to start by saying that this is a lecture that Dr. Mulder had given in past years. You can see his lecture from year prior on the HPM Fellowship website. And when I spoke to Dr. Mulder a few months ago about doing this lecture, he was very supportive of me. He provided me with a lot of information and materials and encouraged me just to incorporate his materials into my lecture. So I have, and I've also tried to synthesize and include a lot of new materials to make this presentation my own as well. But in the process, what I've realized is that I'm continually and still learning from John, and I think we all are. So. Yeah. So here's a photo of poison hemlock, which is a plant which is toxic and poisonous and fatal in small quantities of ingestion. In the ancient world, it was used as a method of execution, famously in the execution of Socrates. And it was also used as a ancient form of medical aid in dying. So it was used to expedite death of people who had insufferable and incurable conditions. But that concept of medical aid in dying was not universally accepted back then. So there was many medical philosophers who really opposed the practice, such as Hippocrates, who we take the Hippocratic Oath from. I will not prescribe a poison or suggest such a course. And that's just to say that it was a controversial topic thousands of years ago, and it remains a controversial topic today. The point of this lecture is not to advocate for or against the practice, but to inform everyone about what the practice entails. So specifically, to learn the difference between the forms of medical aid in dying, to learn the requirements and process of MAID in the United States, and to discuss some of the issues surrounding medical aid in dying using real-world examples. So what is medical aid in dying? What is voluntary assisted dying? It is, in general, the practice where a physician assists a patient to end their own life. And it can come in two forms. So euthanasia and PAS or PAD. So euthanasia is specifically refers to when a physician administers a life-ending medication. And this is not legal in the United States in any state, but it is legal in certain countries in Europe. And in those countries, usually euthanasia takes the form of administering life-ending medications through an IV. PAS or PAD, which stands for physician-assisted suicide or physician-assisted dying, those are equivalent terms, but PAD is the newer, more novel term. They both describe the practice where a physician prescribes, but a patient self-administers the life-ending medication. And PAS or PAD is legal in certain states in the United States, and it's the form that we'll mostly focus on because of that for this lecture. Given the modern history, Switzerland is the first country to legalize the practice in the 1940s, but it took about half a century for any other country to follow suit. They did starting in the early 2000s, and as stated before, it's not legal federally, nationally in the United States, but has been adopted as a practice legally state by state. So here's a good table that really demonstrates the differences in the practice of MAID based on where it is legal throughout the world. And you can see those are the 10 or 11 countries. And they're mostly Western nations, meaning Western Europe, United States, Canada, Australia, with the exception of Colombia as well. Kind of important features here. So looking down at United States, the US probably has one of the more conservative practices of MAID, meaning that medical aid in dying is permissible only in the form of PAD. You do need a terminal illness to qualify for assisted dying. Can't be applied to minors. Can't be applied to a diagnosis of a mental disorder. Can't be made an advance request. And could compare it to a country like the Netherlands up top, and that has a very liberal form of MAID in the sense that both forms of euthanasia and PAD are permissible. You actually don't need a terminal illness for aid in dying. In certain circumstances, this can be applied to minors. They need a terminal illness in those cases. And it can actually be applied to mental disorders such as severe depression. It also can be incorporated into an advance request like an advance directive. So I'd say the takeaway here is the practice of MAID can look really different based on where you are in the world. And here's the map of the United States. So those are the 10 states where MAID is legal, and they're mostly coastal. There's the District of Columbia as well. And most notably, Michigan is not one of the states, right? So why is it important that we know about this? For several reasons. I think one of the main reasons is there's that concept of medical tourism, where people will travel to seek medical procedures, processes. Switzerland has no residency requirements, so historically it was, and presently is a place where a lot of where Americans and other internationals go to seek MAID services. But a couple of years ago, the states of Oregon and Vermont both removed their residency requirements, which essentially means that MAID is more accessible by Americans more than ever now. There's a lower, logistical and cost barrier to entry, essentially. You would think the demand would increase, and you might have more patients that you see that ask you questions about it as a result. Just generally, MAID has a majority support in the United States, as evidenced by Gallup polling. So when Gallup asked the question, should doctors be allowed to end patients' life by painless means, 71% respondents in 2024 answered in the affirmative. And Gallup has actually been doing this poll for decades, asking the same question. And this has actually remained pretty static, the response since the 90s, about so like 60 percentiles to 70%.
Is that like general population?
Yeah.
Is it doctors that are?
No, I think it's a general kind of a layman's poll.
Okay.
But yeah, words matter. So when we ask the question, when Gallup poll asked the question in a different way, so when they say like, should doctors be allowed to assist patients in suicide, that number actually drops pretty drastically. So it drops to above 50%, but in that 50% range. On a local level, in our state, Michigan, we've actually introduced death with dignity, so MAID legislation on a couple of occasions. So in 2023 and 2017, MAID bills have been produced in the Senate and House respectively in their subcommittees or committees. But there was never enough impetus or support to actually bring those bills to a real vote in the state Congress. So it's never been really voted upon. But I think it's not unrealistic to expect that similar legislation will probably pop up again based on history. So definitely something we should be informed about. Okay, so the requirements and process of MAID. I'd say that you can actually look up all the requirements and the process on your state website, state by state in the United States, but they generally all look the same. So every state seems to adopt the precedent of the states before it, and the general requirements look like this. So for patients, the patients have to be adults. They have to be residents of the state with the exception of the states of Vermont and Oregon. Patients have to have a terminal illness with 6 month or less life expectancy. They have to have capacity to make their own decisions, and they must be able to self-administer MAID medications. From the doctor side, the physicians, there must be a attending physician that can certify the patient has the terminal illness with 6 month or less life expectancy and certifies the patient has capacity to make decisions. This has to be confirmed and recertified by a second physician. So it really kind of mirrors that hospice certification in a way. The doctors also are responsible for referring to psych exams if capacity is ever in question by either doctor. And they must inform patients of alternatives, including palliative care, hospice care, pain management. And from the patient's perspective, what the process looks like is the patient has to make a verbal request to their doctor for medical aid in dying. They have to wait 15 days and they have to make another verbal request. After that, they can submit a written document or written request, which has to be signed by 2 witnesses. And this has to be approved by the doctor. And then there is a 2-day waiting period from approval of the written document to when they pick up the actual made medications. So if this was as quick as possible, the whole process would take about 2.5 weeks. The characteristics of patients who seek MAID, at least in the United States, are they're understandably older. So the median age is in the 70s. There's basically a 50-50 split between men and women. The vast majority are non-Hispanic white. Majority are college educated. Most of them have a cancer diagnosis. And the majority of them already have hospice or palliative care on board. And the reasons that those patients choose MAID are a lot of the reasons that we see, or the grievances we see in severe illness. So the top reasons being inability to engage in activities that make life enjoyable and a sense of loss of autonomy. This is followed by a sense of loss of dignity and concerns of burdening friends, family, and caregivers. Inadequate symptom or pain control is actually a more of a minority or smaller reason for choosing MAID. And I think that's maybe because a lot of these patients already do have hospice and palliative services to address the physical aspect. And, I think, all of us hate to think that our life and death decisions are made by our finances, but yeah, in reality, that's at least a reality for 6% of respondents who said that financial implications of the alternative treatments were a reason for choosing MAID. I'm surprised it's that low.
Yeah, honestly. Okay.
And here are some of the medications that we can see used in MAID over time. And looks like early on in the 2000 teens, barbiturates as monotherapies were used primarily, but they got phased out and now they use more mixtures of medications. So the barbiturates basically were phased out due to mostly practical reasons, price reasons, commercial availability reasons, and some concern that certain barbiturates had slower or variable onset when taken orally. Those cocktails of medications that are used now, they all contain a very similar mixture of digoxin, diazepam, and morphine. That bottom one, DDMA-PH, is the most common mixture, and it also includes the TCA and a barbiturate. And talking about those mixtures, there's a lot of important metrics to consider. That's why we use them. But that being average time to sleep or unconsciousness. When you take these mixtures orally, you go to sleep pretty quickly. So just looking at that most common mixture, average time to sleep is 6 minutes. Average time after consumption to death is 1.5 hours. And 81% died within that 2-hour range. But as you can see, there was a real big variance at the ends or at the extremes. So one individual, the max time to death was 26 hours. So clearly not ideal for a patient and not ideal for the family who may have been around them, right? Factors that risk factors for that prolonged dying process are anything that really impedes absorption and anything that imbues the person with tolerance, right? So specifically dysphagia, bowel obstruction, gastroparesis, that all might impede the absorption of the medication, and high opiate or benzo tolerance. heavy alcohol use or tolerance, and strong cardiovascular fitness.
I should have, is this IV or how is it administered?
No, so it's in United States, it's a powder. So all this, that DDMA pH is a powder. You'll essentially mix it in with a half a cup of a liquid, and then you're instructed to take the mixture as quick as possible, essentially. And so just to talk about that now, these are some instructions that might be given to a patient actually if they were prescribed the medication. It aims to really maximize absorption. So, 12 hours prior to medicating, discontinuing things like Maalox, Pepto-Bismol to help absorption. 5 hours prior is not eating any food and drinking clear fluids. And then an hour prior is pre-medicating with antiemetics. And what we just discussed, yeah, it's a powder. They're mixing it with water or juice, half a cup of it, and instructed to underline, drink all the liquid within 1 to 2 minutes. And, in addition to that, it's a mixture that you have to self-administer, but you can do it through a G-tube. And my research, you could actually give it per rectum. But, you have, the key part is you have to self-administer. So, a lot of the patients that we see with serious illness who might be paralyzed or very debilitated or very weak, they would not be able to participate in the process because they probably couldn't self-administer. This graph here, it shows just the change in the amount of prescriptions of MAID and the deaths by MAID over time. So it's a 20-year time frame. The blue line is Oregon, where it's been legal for about 20 years. The blue solid line would be, again, the amount of prescriptions in Oregon, MAID prescriptions given in Oregon. And the dotted blue line at top would be the amount of deaths by these prescriptions over time. So we can see a lot of trends here, but essentially, so the big ones are, well, ever since legalizing the practice in the state, there's been an increase. And at this point, there doesn't seem to be a stop or end to that increase in popularity of the practice. Another thing that we can see is, looking at Oregon specifically, that rate of prescription has increased by a factor of about 9-fold over the 20 years. And that rate of using those medications has increased by a factor of 6-fold. So if we look at that endpoint, that 2020 data point for the blue line, about 2/3 of individuals who pick up the medications actually use it to completion, which tells me that remaining 1/3, they're either having second thoughts about the practice and don't use it, or they possibly die of their terminal illness prior to using it, right? But yeah, so I had a question that I had based on the last slide was, what percent of deaths are actually by MAID in each of these states or these countries? And some of the data I found for this was available on that state or nation website. Oregon, interestingly enough, so about 0.5% of all deaths in Oregon are by MAID. And this is in comparison to some of the other nations like Canada, where that number is a lot higher, actually. So like 4% of all deaths in Canada are through the medical aid in dying process. Netherlands is 5%, and in Switzerland, that number was less than 2%, but I think kind of close to 2%. And another question I had is, well, if our rate is like 0.6% in Oregon, could that ever approach Canada's rate or Netherlands' rate? And I think it's unclear to me because one thing I noticed is that there's not an apparent correlation between the amount of time the practice is legal and, the popularity of the practice, because, Canada actually only legalized this in 2016, so 20 years after Oregon, but the practice is like 8 times more prevalent. Whereas a country like Switzerland, is 60 or 70 years before the other country, and the practice is kind of in between, or the rate of using it, 2.2% around. So I think just it opens up in my mind, like, what are the factors in a nation or in a country where that would promote or go against utilizing MAID, like whether that be social, financial, or cultural. Covered a lot of the basic material up front. So the latter half, I want to talk about some individual experiences from individuals who were either going through the MAID process or affected by it, and kind of the issues that were brought up by the process. So here, so this is a case involving a Canadian, Christine Gauthier, and she was a Canadian who served in the military in Canada. She actually was injured in service and became a paraplegic. She went on to compete for Canada in Paralympics and became a multiple-time gold medalist in paracanoeing. She was trying to get a wheelchair ramp installed at her home for the past 5 years, but was upset when one of the government caseworkers told her that they could give her assisted dying, even offering to supply the MAID equipment for her. So she was really upset with this. She testified publicly, testified to the VA Canadian committee, and some of her statements in that public testimony were, I can't believe after all this time, not only will you not give me the equipment I need to live, but you'll help me die. It's really hard to understand this when you feel or may be blinded enough or stupid enough to believe that your government is there to help you and not in your life because you're becoming too pricey or too much of a problem. So really a weighty statement there. And some of the issues I see in Christine's case in particular are the concerns that MAID may be used as an inappropriate solution to an addressable problem, right? So in Christine's case, the ideal solution was to provide her with some adaptive equipment so that she could function better at home. But MAID was kind of offered at least as an alternative solution, right? Not ideal, and yeah. And I think that concern of using like MAID as kind of a alternative, inappropriate catch-all solution to things that you can't easily deal with, the concern is using that to not target, but to direct towards vulnerable populations, those with physical disabilities, mental disabilities, or even financial concerns. So like someone comes to say, hey, I can't afford my medical treatment. Your doctor or provider says, have you considered medical aid in dying? Right? That's clearly inappropriate and like a simplified encounter, but kind of demonstrates that point. And extension to that, I think there's that concern about the compromise of that patient-physician relationship based on the above. But I will say that, countries like Canada and other nations do enact policies to kind of mitigate against this issue. So the Canadian government, in response to Christine, had stated that it's their policy or protocol that no healthcare provider, no one involved in the care of the patient can offer it or discuss MAID until that individual requests information or about MAID. So, okay, so the second case I have is that of a Dutch woman named Lauren. So she's a 27-year-old. She reveals that she has diagnoses of autism, ADHD, she has an eating disorder, depression, anxiety disorder, history of complex trauma, and she actually documents her process in the Netherlands for seeking medical aid in dying for myalgic encephalomyelitis, which is also known as chronic fatigue syndrome. She wrote a blog online, and it's still viewable on WordPress. And the blog is titled Brain Fog, My Life and Death with Myalgic Encephalomyelitis. And this actually spans the course of 2 years. And, I encourage anyone to kind of read that blog online. And she talks about the process, but she also talks about kind of the suffering that she had with her disease. So she talks about, with her severity of the encephalomyelitis, intolerable fatigue. She talks about some post-exertional malaise and nausea and vomiting after exerting herself, and in general, the brain fog or difficulties with concentration. One of her entries, she states, she indicates, I started this blog to write openly and honestly about my illness and euthanasia process because I think we are all still far too secretive about this. I want to break that taboo. I want us to be able to talk about difficult things. Talking about death should be the most normal thing in the world because it's part of life and we will all have to deal with it eventually. And Lauren's case in particular, I don't think it became popular or well known until she made a viral post. So she posted on Twitter. Post that follows. So, yeah, this is from her account. So she says, this will be my last tweet. Thanks for the love, everyone. I'm going to be at rest a bit more and be with my loved ones, enjoy a last morbid need for me. So, as the kid with the thumbs up at the dental office, presumably getting some aesthetic, and says me getting euthanized. And she revealed that she was approved for that euthanasia process in the Netherlands. And, I think we can all in good faith say, yeah, this is an individual suffering so much, right? And they're using kind of humor to diffuse or handle or cope with such a painful reality. But there's the issues that present itself that were brought to attention by her case was that, for one, what do we do about applying MAID to non-terminal conditions? And that's not the case in the United States, but I think that really draws attention to that concept of the slippery slope, being that, if we have MAID for terminal conditions in the United States, 5 to 10 years down the line, does that now become approved for non-terminal conditions like chronic fatigue syndrome? 5 to 10 years later, does that get improved for psychiatric disorders? And I think at the end of the slope, what the logical conclusion would be, do you even need a diagnosis to qualify for assisted dying? And that's a question, I think, that really has such huge moral and philosophical concerns. And clearly, I think, when I'm thinking about it, there's a lot of practical concerns too, right? What does the society look like? What are the social, demographic, cultural effects by accepting this as a treatment for terminal and non-terminal conditions? Just looking, when I looked up like some information, because I was curious, I said, well, how many people have chronic fatigue syndrome in the United States? And it's about 1%. You look up how many people have depression, and I think the lifetime prevalence is like 30%. So, what are those demographic impacts if this is a practice that's used more frequently? Other issues, the issue of psychiatric comorbidity. So, and this is something that Lauren documents in her blog. So she admits and says that she has a lot of these issues, right, from complex trauma. I think the question that a lot of people had is, what effect do those comorbidities have in influencing a person to choose MAID? But again, there are some safeguards involved. So she had several screenings. She talks about having multiple psychiatric referrals and psychiatric screenings, and she was approved for the process. And finally, that last point I'd like to talk about is that social contagion. So that's kind of the most interesting point to me. It's that idea of the social media. So based on her Twitter post, right? Social contagion is the idea that based on by posting social media, we can that we might influence others to mimic that behavior. So I guess the idea would be if someone posts a meme or content that might bring something to attention or to normalize it, that other people might mimic that, or may choose medical aid in dying when they wouldn't otherwise have, or that they would choose MAID even if they don't share that real extreme subjective internal suffering that someone like Lauren might have had. And I think I'm sure there's a ton of data and research independent on social contagion as a topic in sociology, but I haven't looked into it that much. So. Yeah. All right, and here's the sarcopod. I couldn't find a picture because I didn't have a free use image of this device, but I really encourage you, if you have your phones on yet, Google it. Yeah, because it's really kind of interesting. It's basically a sarcophagus, as the name implies, but it's plastic. It's has a see-through cover, and it's a device that was created somewhere in Europe. And the idea is that you enter the sarcophagus, a person would press the button, it would inject nitrogen gas into the pod.
It looks so like Star Trek or, like.
Exactly. That's the first thing I thought. So, whoa.
Launch me right now. Yeah.
It's it's pretty interesting because in fact that sarcopod, it's 3D printable. So yeah. So I wonder too, is the idea behind it is that it's so the manufacturers essentially they wanted to demedicalize the dying process.
Yeah, let me just download the place. Oh my gosh, that's crazy.
That's kind of what I asked. It's like, you have a 3D printable plan and you're supposed to be able to have widespread availability and print it out yourself. But I don't know much about 3D printers, but I would think that the 3D printer had to be the size of like a room.
Yeah, it would have to be
gigantic.
like commercial.
Yeah, so
Yeah.
I don't know how much that's actually feasible to
So
be
interesting.
a widespread device. But yeah, so the inventors of the device said, they wanted to demedicalize the process, meaning they quoted, "We want to remove any kind of psychiatric review from the process and allow the individual to control the method themselves." It was meant to be like widely disseminated, and it was actually used. So, it was used in Switzerland, and we were talking about medical tourism, and it was used by an American woman who traveled to Switzerland. Everyone, or the people who were involved and facilitated the process in Switzerland, though, were arrested and charged because it did not fall within the regulatory process that was established. Yeah.
Mm.
So there are kind of those rules and regulations. So clearly that's one of the issues here. But the question I had too was, this is a kind of a interesting technology. If we have these novel technologies of the future that make dying or the dying process either safer or less painful or more aesthetic or easier, and more widespread, particularly, will that eventually bypass the regulatory process altogether, right? And right now we're talking about regulation of medical aid in dying with doctors involved, but in the future, if people are having 3D printable widespread devices, will we eventually even be removed from that process? And that's just more of like a thought experiment, but kind of one of the issues that I was thinking about. Okay, Jack Kevorkian. So I don't think I could give this lecture without mentioning Jack Kevorkian. He was like growing up in the 90s. I saw him on TV, and he was the figure that was, for better or worse, associated with medical aid in dying, and he brought it to national attention. So he was born, raised, and practiced in Michigan. He was a pathologist by training. He became famous, and he earned that moniker Dr. Death for participating in over 100 cases of PAD. He would document his cases, meaning he would keep some records, written records, but also he had videos of screening process, and he had videos of sometimes of the administration of the medications. And he was really an advocate for patients being able to, again, control that process and being able to choose what they wish, right? He had some inventions too. So when looking it up, he had a device called Mercitron, which was just kind of like a gas mask with CO2 administered, or not CO2, carbon monoxide for painless asphyxiation. He had this device called the Thanatron, which is a death machine, kind of a grim name, but it was like a series of vials and tubing on a timer, and the patient would press a button and they would be sequentially administered the various medications based on the timer. Yeah, kind of a novel guy, right? He's trying to create these devices for the patients. But he was sentenced to prison for murder because he performed euthanasia in certain cases, and he documented it and I think admitted to it. But he was sentenced and served, I believe, around 8 to 10 years for this. And during the trial and during the investigation, there were a lot of concerns raised about what he was doing. There was no standard legislation or protocol at that time. But the concerns were that he was improperly screening individuals. So his screenings could be very brief, and the PAD could occur immediately afterwards. So there was no like waiting period built in to think about it more. There was concern that some of his patients should have had psychiatric referrals, should have had pain referrals, should have had palliative referrals. And I think most concerning when I was reading was that, on post-mortem autopsy, some of the patients didn't have terminal diagnoses. So I'm not sure what his level of kind of screening for those patients were. And clearly this is a case of, again, much like the sarcopod, kind of issues about regulation and oversight. But during his trial, he made the statement, if you don't have liberty and self-determination, you got nothing. And this is the ultimate self-determination to determine when and how you're going to die when you're suffering. And, what I'm getting from this is he's making that argument for MAID based on a couple of those principles of medical ethics, the pillars of medical ethics. Clearly for him, liberty and that medical pillar of autonomy, right? So he's saying, hey, I place high value on our liberty and autonomy, so the patient should be able to choose what they wish with their body, right? He also notes, that ability to relieve suffering, right? So appealing to that concept of beneficence, right? Relieve suffering and doing so by seeking MAID. Some other arguments that I've commonly seen when researching is most of that by regulating the process, we can reduce some of the misuse or abuse or improper screenings. But, and the philosophical argument that killing is not always murder. So, if we accept that medical aid in dying is ending human life, which is killing, we can also recognize maybe that killing in our society is sometimes condoned and sometimes allowed, right? So self-defense, capital punishment being common things that people point to, other forms of killing that are permissible. Some arguments against MAID, I think they generally focus on that pillar of non-maleficence, kind of that, like going to philosophy 101, right? That deontological argument that we have to judge the morality of the action on the action itself. So if killing or taking human life is morally wrong, that would be maleficent, and then we have to say the whole process is morally wrong. And that extends to other issues that we've talked about just in this lecture, even corrupting the role of the healthcare provider, possibly eroding trust between patient and physician, patient provider, kind of what we saw in Christine Gautier's case. Risk of abuse or misuse, or even improper screening, kind of like what we saw with Orkin, and the slippery slope, which we discussed when talking about Lauren's case. Okay, so just want to say that, the arguments that you find convincing or against, it obviously varies from person to person, and it's really dependent on your moral framework, and that we've got to recognize that really does vary between each of us based on our religion, based on our philosophical framework, and our individual morality. So finally, I think it's important that we compare MAID to some of the practices that we see and perform in our work as hospice and palliative care doctors. Specifically, withholding and withdrawing life support. Withholding or withdrawing life support and MAID can both result in a state where a patient dies, but withholding and withdrawing life support is not legally or ethically equivalent to medical aid in dying. In a couple ways, right? Mechanistically, causatively, cause of death is not the same, for one. When you withdraw or withhold life support, death is by illness or underlying injury, whereas death from medical aid in dying is directly from the meds that you administer. Probably more importantly to the intention of the act, right? So withholding or withdrawing life support, the intention is preventing harm with intervention, whereas medical aid in dying, the intention is ending life directly. So like withholding CPR, right? Our intention is to prevent the harm or debility of the chest compressions. I think one of the more apt comparisons, and the one that kind of creates a little bit more ambiguity, is when we perform palliative continuous deep sedation. Because again, both MAID and palliative sedation can result in patient dying often. And these aren't equivalent either, though. So palliative sedation is not equivalent to euthanasia or PAD, even though palliative sedation can hasten a patient's death. So, mechanistically, I think this is where a lot of the ambiguity occurs with us when we're examining the practice. But mechanistically, when we administer palliative sedation, in appropriate doses, right? It's the goal and the effect is sedation, right? Not death. So you should not be immediately dying from the medication that you're being given. Could you die from your underlying illness or disease? Yeah. But could you also die from like a second order effect of the sedation? Yeah. So if you're sedated and it's in a state where you're not eating or drinking, could you die from kind of that second order effect of dehydration in the process? Yes. But I think that's where when you analyze the practice in comparison, you really got to look at the intention. So when we're looking at the intention matters, right? The intention for the palliative sedation is not to kill, but to reduce suffering by placing a patient in a state of unconsciousness where death may be a foreseeable consequence. So that's going back to the double effect, right? The intention is reduction of suffering by sedation. Possible consequence is death of the patient. And this double effect doesn't hold with MAID because it's kind of reversed, right? By definition, medically aided dying, your intention by the fact of it is aiding in death. And I would hold that the secondary consequences or effects, the second order effects are, or secondary goals are either respecting patients' autonomy or reducing their suffering, right? Or a combination of that. Okay, so talk about a lot. And yeah, heavy subject. I'm sorry about bringing up such a heavy subject and more, but importantly, is something that I think we should all know about the practice of. And my point here was to inform everyone about MAID, the fact that MAID consists of both euthanasia and PAD, that MAID is legal on a state-by-state basis, specifically in the form of PAD in the United States, but you have to see what state you're in, and that those requirements for MAID are generally common amongst the states. And as we've been discussing, there are so many ethical, legal, and pragmatic issues that we have to consider when talking about MAID. And I think as palliative and hospice docs, we're going to be the ones that people are going to eventually turn to for insight and opinions. So being informed on it is really important. And I know I've said brought up a lot of issues with the practice of MAID that I've encountered in my research, but here are some organizations that I encourage you to check out. So all of these organizations advocate for the practice of MAID, and some of them provide some testimonials from friends and families about what they've viewed as a real value to their loved ones in that dying process. So I've included some of their materials in this lecture too, right? That's that. So some references and deep and heavy topic, but thank you all.
Thank you. Well done, Dave. All right. Good topic. Tough topic. Good. Thank you. Thank you.
Yeah, I was pretty interested in the topic because I didn't really know anything about it. Okay, well, I probably should know. And it's a deep dive, so there's so much information to.
Yeah, people are gonna ask about it.
Yeah.
I'm upstairs at hospice right now, and we've had a couple patients in the past 2
Oh, yeah.
weeks ask about it.
Wow.
It's like, well, not here.
Right.
All right, so here's a question for you. All the medications and methods, while the medications and methods may have moved on, the ethical arguments don't seem that different from what they were in antiquity. Do you think, or what do you think has caused the rise in popularity in the last few decades in the West?
Wow, that's a hard question. That's I mean, I think probably to me would be, if just my opinion, is kind of a shift in our what we value. So like when you look at that pillar of medical ethics, right? When you look at arguments for or against, you're convinced by what you hold highest. So I think what I realize is that in medicine today, it seems like people hold that autonomy as kind of
like
one of their highest.
from paternalism to individual autonomy. Yeah.
At least in medicine. It's been like that.
Yeah.
I have a few thoughts. I mean, when you ask about the slippery slope, I hadn't even let my mind go there, but I'm like, well, what about people who are poor or considered undesirable in this country? Is that going to be like given as an option? I mean, like, I'm not asking you, I'm just saying.
Like, yeah,
I mean, it's like, all right, well,
Foresee that and. or like
suggested
an
by
ageism.
the government.
Yeah, like the person that in Canada, right, who asked for the ramp and.
Oh, that makes me so mad. 5 years for a
know.
ramp? Are you kidding me?
So frustrating
Well,
to hear.
That's the slippery slope. potentially.
Call up the local handyman.
I mean-
like,
Right, yeah, right.
May not even be a ramp. It's like, well, it's been on the street for 10 years and
Yeah.
It's ridiculous.
dragging our sick. Anyway, I'm not trying to say we need.
Well, I'm gonna throw
but
another twist on that.
Yeah,
What about that person who doesn't want to spend all of their retirement savings? They say, I want to leave my kids an inheritance.
Oh my gosh, I've heard that too in the past couple of weeks. It's so
I
sad.
literally have an uncle doing
But that's what actually kind of struck me, is not even like that doctors are the ones, or healthcare providers or are the ones trying to influence patients, but
I
that
think that's you.
motivation.
That is.
Sorry.
But no, that internal motivation, right? What happens when
Yeah.
it comes to the person saying, well, this is kind of something that's a reality to me, so maybe I should do this, right? Kind of a,
I don't want to spend $10,000 a month in the nursing home. I'd rather have my kids go on a nice vacation.
Yeah.
What do you do with that?
That's
Yeah.
not an unreasonable thing to think about. As
That's
the person,
a testament to our system as well, and like where we as a society invest our resources, the care of our sick and elderly.
Where you have to spend down, right,
Yeah.
before you can get assistance with
Yeah.
assisted living or
Yeah.
skilled nursing.
Or like access to private duty nursing. There's one, it's very expensive, and two, the staffing. It's so hard to find staff. That's
our population's
Yeah,
definitely
it's-
aging.
tough.
And so we're,
There's a huge social cost to the family as caregivers.
Oh, yeah.
Hmm?
It is Ken Hansen. David, great topic. I'm glad you tackled this. I did a similar presentation and did a lot of research and reading. I wanted to add a couple things. There was one article I came across where they had surveyed healthcare providers. So this is the healthcare team that's taking care of the patient, and how they had dealt with a request from the patient to attend the death. And there was a lot of moral dilemma, for a physician who says, hey, I want you to be there when I, drink my cocktail. And most physicians had significant issues with that. So I think that's something that we're all going to have to work through if we get into a state that allows this. The other is capacity. All the states must require the patient must have capacity, and everybody has a pause between the first request and then going and getting the prescription filled. And I know a lot of patients are losing capacity at that second evaluation. And then suddenly it's like, well, I'm sorry, you don't have capacity to make a decision. And then they're kind of left, in a lurch, because the family's like, well, now what do we do? The third thing is there's been case reports in the ER literature about patients doing MAID with home remedies in states where it's not legal, and then kind of botching it and showing up in the emergency department. And then now, is the patient suicidal, or is this just an expression of autonomy, right? So you get into a lot of these legal quagmires. So yeah, I also had a patient recently, and if anybody wants, to support this, just send them to Vermont. If they're on hospice, you make a referral to another hospice agency in Vermont. They will travel there. That agency will do everything. So I will speak one more comment. This has come up before in prior years, and I think the discussion is always, they really need a palliative evaluation first before we consider this, right? And we tried every option to control their symptoms. So, thanks.
Well, can you bring up an interesting point of that role of hospice and that juxtaposition of hospice? I mean, we as a specialty are fighting against that stereotype of being Dr. Death. What are your thoughts, like a hospice taking on this sort of thing?
Like, should it be a separate entity?
Should it be a separate entity? Is it
Entirely.
something hospice should take on if it's legal in your state?
I mean, that's a good point. I feel like if we're trying to get people to understand the true purpose of hospice and the meaning of hospice, and then you take on this role of doing MAID, then is it just gonna make society think that their initial thought of hospice is what it is, and we can never really change that mindset? I guess that's a big concern if hospice does take on that role.
A lot to think about.
I can't-
I love these kind of conversations. I'm trying so hard not to.
You want the truth? I can't do it. I mean, at some point you gotta just put up, I mean, I'm not trying to be flippant and say this isn't a good discussion. It's a wonderful discussion. It's an important discussion, but if you're like, if you in your heart have to resolve your ethical dilemmas and there's a line, this is a line I'd have a lot of trouble with. Now, the only time when I really started thinking about, hey, this might be something to consider is some of these neurologic cases where their mind is totally with it and their body can't move. And I'm like, I don't know if I want like that.
But you can't decide based on how
You can't.
you would want to live or die.
Well, no, but I mean, well, when I had heard these kind of topics before, I would say, no way would I even consider doing this. But then when I heard about some of those like ALS cases, I'm like, you know what? That's starting to make me think, oh, but I'm not, I mean, but if you're like, look, you gotta make it, if you have to make a decision, but I mean, if it became legal in Michigan, I don't know what I'd do. I might be like Ken and say, well, there's another hospice to go. I mean, if you're asking the question, Joel,
And I mean, I think that kind of extends to a lot of things that we do as physicians, like think of different procedural things, like, or medications that maybe you're not as familiar with, like, ooh, like
Yeah.
my comfort extends to being able to prescribe these things and follow these things for you. But I'm not as familiar with that. I don't follow any or very many patients with this, but I know somebody has more expertise in that area, so I will refer you to them. And I think that's appropriate, like knowing the extent of what our comfort with our scope to be able to serve the patients that come to us, you know?
think of this a lot.
Yeah.
Obstetrics.
Yeah, this is Ken again, and I've kind of thought this through, and what I would say is that, is this kind of revocating hospice? You know, this is not something that we kind of support. If this is something we want to pursue, we'll refer you back to your primary care physician who can write the prescription. But, you know, in California, there was some controversy where a number of hospices were not disclosing that they did not support this and would not make referrals. And then once the patients enrolled and they made that request, then they came out and said, oh, we don't do that. And then the patient was left trying to find another agency that would make the referral. So I think there's a lot of ethical issues that need to be worked out. You know, if you move to one of these states where it's legal and you're a hospice medical director, you've really got to have a policy and a stand, right? You either got to disclose this from the moment you do the evaluation of the patient to say, we don't support this. And if this is something you might want, you're going to have to go somewhere else. Or say, well, we're going to set up a process, you know, because you're going to have to decide if you're going to write that prescription, right? And then if you do write the prescription and they want you to be there, you see how it becomes, again, slippery slope, right?
I think about our ALS patients and like you alluded to, some of our other patients with neurologic disease and just the physical ability to be able to self-administer.
Yeah, I mean, ironically, the people that we might consider, you know, it could.
Yeah, and then you're kind of,
Your family.
if somebody is considering this, and they're faced with one of these disease processes and have capacity. Let's just get that one out of the way. They have capacity and they're looking into this as an option, looking ahead at knowing the disease process and the suffering that they might encounter, deciding when. I could see that causing, like an internal struggle for the patient and their loved ones and the physicians taking care of them, the rest of the healthcare team taking care of them. But it can be so hard. Like some of our ALS patients have such rapid changes, and some of them are around for a longer time, so
Few of them can live years to a decade.
yeah.
Some to live 2 decades.
And so to be able to try to anticipate and make that decision to say, okay, this is something that I want for myself and my end of life care plan with dignity for myself. At what point? I want to live as long as I can with good quality of life. But at what point do I say, okay, this is enough of a decline and will you miss your window? And then struggle with that, kind of like that existential kind of dread around dying. And did you miss your chance for death with dignity? I don't know. It's just, again, this is just one of those like, things that make me wonder. But I think some of the comments kind of brought up about like having a protocol and, are certain diagnoses that are allowable for this type of process. I think those are all things that we would have to address if this is something that's going to be offered, So, I don't know. Things that make me think.
Yeah, a lot of questions, but.
Yeah,
not a lot
so
of
many
direct
questions
answers.
and not a lot of answers, yeah.
And
And I think that makes it hard for pushing through like policy. A lot of questions and not a lot of answers.
Well, in addition, people are going to come to you
Oh, yeah.
and ask you for it. And you have to prepare your response. I've had people specifically refer to me because they've brought up to their neurologist this specific issue. Their neurologist said, well, let's have you talk to the palliative care doctor.
Yeah, that's the answer they have prepped.
Yeah.
Now we gotta go a step further. How do you approach that, Dr. Phillips?
Well, I think like David said, I have to be honest with where I am with my patient and say, well, right now, you guys all have the safety in Michigan of just saying, it's not
Right,
legal in
it's not
Michigan,
legal
I'm going to
here.
lose my license over it. But you can be open with them, and you can be vulnerable to the point you want to be with sharing your stance or your view on it. And I try to address the suffering. I try to ask the why. Why are you asking this? What is it you're concerned about? How can we mitigate those concerns? Number one off the bat, it's just like any other history and physical we'd be taking, is you want to get at the story behind the ask. Oftentimes I've found, and this is a whole it's another realm for discussion that we can either open up now and not get to the case, but there's, particularly in neurologic cases, there's always voluntarily stopping of eating and drinking. Or there's not placing a PEG tube, or there's not using the non-invasive ventilator. Those are all things that we've said are ethically and morally permissible to do, to not start a treatment that would not provide benefit, or the burdens of treatment are too high. So I'll have those conversations. And in my experience, many people can at least get behind that idea, and it gives them something to think about,
and some control.
Particularly if you can't self-administer. I distinctly remember one patient, after having conversations like this, who had a plan and took matters into their own hands and did end their life earlier. But this was somebody who also knew the system and knew what to say to doctors. But I'd say for the most part, it's being honest and exploring the idea and not shutting the idea out, but getting behind the why that really is most helpful and therapeutic. And I don't believe, to my knowledge, I've had patients go down that route of trying to go to Oregon or Vermont or places like that.
Yeah, it seems like at the core of this is alleviating or mitigating suffering. Which I think is what our specialty is really good at. You know, being creative and finding ways to help with that symptom management to foster quality of life in the time that we've got.
Thing that makes it difficult for me though is when you look at the reasons that people are choosing, and it's, you know, the symptoms are kind of the secondary, but it's
Yeah.
really those deep existential and like
Yeah.
autonomy and, you know, engaging in your prior social roles. That's
Which is its own kind of suffering,
Yeah.
right? That loss of self
maybe we
in a
can
way.
treat it too, but maybe outside the scope of pharmacologics, right? And it's such a bigger thing.
And Jody and Mike have a conversation going on here too. So Jody says, "Thank you for the discussion. I recently presented on this topic, and one side, the general public tends not to consider is the position of the physician who is responsible for prescribing. It's an important part of the discussion." And then Mike adds, "Right, when autonomy rules overall, physicians become service providers."
Yes. Yeah, and Dr. Trexler is unmuted.
I also wanted to say that when something is legalized, then eventually it becomes a right and an obligation, and people could be punished or penalized for not participating. So that's one of the conscience concerns that I and many other physicians might have regarding MAID. And it's also interesting to note, David pointed out that the majority of the reasons people requested are not related to physical pain and suffering. It's related to loss of autonomy and wanting to basically make their own decisions about when their life ends. So that's really the key issue, not necessarily the pain and suffering side of it, which is unfortunately what is put out there when they're proposing bills. It's always focusing on the pain and suffering. It's not focusing on the underlying issue of autonomy.
Absolutely right.
Well, I mean, you look at like some of these people that have given like Michael Jackson propofol. Was it Michael Jackson? I can't. I mean, the doctor was litigated. It's like maybe Michael Jackson wanted it. He gave it to him, but doctor's in trouble, you know? I mean. Any of the Corwell folks have anything to add?
Yeah, this is Simi. We actually, as a physician group, got together a couple years ago to talk about this. We have no solutions, just that it is on our mind. It's a challenging situation for all the things that people have mentioned. You know, one of the things that I personally worry about is, does the regulation of PAD increase disparities in healthcare? And, you know, for the reasons that we somewhat touched on, but not only, not only allowing those with more resources to have that freedom, but also using this as a way to coerce is a strong word, but I will say it, for patients that we may, because we can't talk patients into things. We can try to get them to do things, you know, and fulfill our agenda. I really worry about that aspect of it, but nothing really more to add than what's already been discussed.
Yes, I wanted to add, just kind of follow up on Timmy's. I think we all need to, going back to the protocol, are we going to demedicalize this? As in, here's your prescription, go home and do what you're going to do, don't involve me, versus, well, you're currently being cared by your hospice agency and we will have the hospice nurse there in case something goes wrong.
Excellent perspective. If you're gonna do it, how can we do it safely?
I mean, I have opinion. I don't think we should demedicalize it. I mean, I think we need to be involved, right? In Switzerland, there are no physicians. You just show up to this little resort and they give you the medication and you die. And
They get a, what is it, a core pod or whatever they call it?
Oh, yeah, the sarcopod.
right. And I think all jurisdictions in the United States require physicians to be involved in this process, right? I don't, the freaky Dutch, I fear will pretty soon you can just go to the pharmacy and pick up the medication on your own, like birth control. It's just kind of how they've really pushed it is a little concerning, but.
Right.
Good topic, Dave. I mean, it is
Yeah,
an excellent topic. And
Like
one
you
to
said-
consider.
Yeah, something that maybe a lot of us haven't had any exposure to, especially in our state where it's not legal, but knowing that patients are gonna ask about it, have kind of a framework for the conversations that we're probably gonna have with patients who ask, and knowing some of the states that have that available if somebody keeps pushing for that as part of their care plan. So thank you.
Thank you all.